So I'm here on behalf of illness and disability. I'm all in favor of prevention, but how many people here hope to grow old? There are 3 or 4 people who didn't put up their hands. But all the rest of us hope to grow old, and guess what happens as you grow old? Even if you've exercised and eaten yogurt, done yoga, you will have a period of serious disability. I'm speaking mostly about that phase of our life and using that as an example for how we're trying to change the healthcare system. So the problems that we see are that healthcare costs are distorting the economy and becoming unsustainable. So that healthcare costs now at the state level are consuming the opportunity to do anything else. Healthcare costs through Medicaid and Medicare are now almost double what they are in most other countries. Patients and families don't like what they're getting. They're finding being frustrated, they're fearful, they don't trust the care system, and guess what? So are we. Clinicians are frustrated, fearful, and angry. So we need a new care system. We need a new way to put it together. I'm going to show you at least some of what's now being tried and what I think would work better, but I'll start with my mom. My mother's now 94. She lives alone in a little town in western Pennsylvania, far beyond the reach of most social services. She can barely make it bed to chair, chair to kitchen, kitchen to bathroom. She insists on going to the basement to do the wash. I told her I would put a mattress at the bottom of the steps so that when she fell, she would at least have a comfortable place to lie. But that's, how many of us are going to be, fiercely independent despite substantial disability. About 4 years ago, my mother picked up a tiny little suitcase, felt something give in her back, ended up going to the emergency room saying, "I've fractured D12. Those of you who are very old will remember that at one time the thoracic vertebrae were called the dorsal vertebra. My mother was trained in that era. The ER doc said, "No, you haven't fractured D12, you just have a urinary tract infection." She said, "You're full of it," and went home, came back 12 hours later, got a different ER doc, got the right diagnosis, got an x-ray, yes, she had fractured D12. What happened then is an illustration of just how fouled up the care system is. My mother got every imaging study known to man over the next couple weeks. She had an MRI, she had a CT scan, she had a bone scan, she had things I'd never even heard of. She ended up with 6 different imaging studies. I said, "Mom, why are you going through this? Every time you go out for one of these procedures, it's terribly painful, and what are they hoping to prove?" My mother, incidentally, is a doctor. She said, "They're looking to see if I have metastatic cancer in my spine." I said, "And what are they going to do? Like, what's the nifty outcome if they find it?" She said, "Well, they just want to know whether that's the cause." I said, "Mom, you have 3 other fractured vertebrae. You've got osteoporosis up and down your spine. Like, it's really likely? And what's the advantage of knowing 3 weeks early?" No advantage. But guess what? Every radiologist was paid. Every procedure was paid. So was the corset that was made, custom made for my mother, would have fit Magic Johnson. When you sat it on the chair next to her, it came up beyond her chin. Medicare paid for it. So my mother ran up $10,000 worth of expenses around a older person's fractured vertebra. Despite my best efforts to persuade her not to do these things, I finally persuaded her not to have the orthopedic surgery that the orthopedist wanted to do. This is called vertebuloplasty. You inject plastic into the spine and reinflate it so that it has its normal height. It has been shown to have exactly the same functional outcomes at 6 months as doing nothing. Most countries do not pay for it. We do. The orthopedist would have made, or then the hospital would have made around $20K for doing that, $20,000 for doing that procedure. It increases the rate of fracturing the vertebra above and below. That's its only outcome. I said, "Mom, you do not want this procedure. It's the only procedure I know of that has had 2, count them 2, randomized controlled trials of sham procedures where people did not know whether they actually got it or not, has exactly the same outcomes at 6 months. Why are we possibly doing that?" But most people would have had that. So the usual cost in our system would have been over $30,000. Those of you in home care, what did she need? What would have been optimal care? Somebody want to call it out? Bed rest and physical therapy, right, and a good dose of opioids for the first couple of weeks. Somebody to make sure that her bowels moved, someone to make sure food got brought in because she wasn't likely to be able to cook. Could maybe have run up a bill of maybe $3,000 to $5,000 if you'd really been diligent about billing, but not really much more than that. That's the waste in our medical care system. Everybody got paid for all that stuff they did to my mother. And the benefit was really in the $3,000 or $5,000, which she did not get because we did not send a home care nurse out. Now, she in fact had enough family to help her out and things kind of went okay, but still, in most countries, she would have been able to be sent home from the hospital with a promise that the visiting nurse would call her the next day, that they would watch over her opioid prescription, they would get her bed rest until she felt a little better, then they'd start therapy to make sure she didn't decondition more, and that would be it. She would have had one x-ray in the ER to prove that she had the right diagnosis. How could we get to this? Well, first off, we have to recognize that we have incentives for procedures and stuff. We get paid on the amount of things we do, not how much good we do for the patient. We have disincentives to deal with behaviors and supportive services. So it's very uncommon to be able to get people into good care systems if the major problem is behavioral. The wait list in a county next to where I live for behavioral health is now 1 year long for people who present with the challenge that Representative Carter was talking about of opioid overuse. Somebody who's ready for treatment would have to wait a year. Think about that. If you had to wait a year for valve surgery, we'd all be up in arms. And the American disinclination to accept disability and death. I mean, my mother was really unlikely to ever be quite as healthy as she had been the day before she fractured her back. But we are unlikely to accept that sort of an outcome. We think that, oh, but inflating the vertebra is going to do something wonderful. And then the big thing is we've just escalated our prices. And if you need any story about that, just look to the recent scandals over pharmaceutical prices, where one drug company buys up a drug that is only available through one manufacturer and jacks up the price 5 times, 10 times, 1,000 times, and there's no break on that. There's no stopping point. You can just add zeros as long as you like. And at some point, people have to stop buying it, but not in Medicare. In Medicare, we have to buy whatever it is that serves the patient. So what's been tried? Well, we've done lots of stuff. There's skin in the game. That is making people pay a higher percentage of what it is that they get. That could be in the form of initial payment, some big deductible, some high deductible health plan where you have to pay the first $5,000 each year. It could be a percentage of everything that you pay for, so 20% or 30% of everything that you get. Problem with this is that the evidence thus far is that it cuts down on useful things every bit as much as it cuts down on unuseful things. Patients are in a very bad position to sort out which things they should have gotten. My mother was a radiologist. She should have known that the imaging studies were garbage. Why did she go through all that? Because the orthopedist says it's important. My mother could have stood up to that, but she didn't. Could we expect the average cook, the average laborer to stand up against the orthopedist? Of course not. So that hasn't worked terribly well. We've reduced prices in some cases. The Medicare just makes broad cuts and says we're paying you 5% less next year. That, in general, hurts good providers at least as much as bad providers. Forces consolidation so people can stand up against these price cuts, especially if they're being done by commercial plans. And it encourages people to pay something on top to get decent service. And that, of course, benefits people who can pay. So it leaves behind the people who can't. So that doesn't work terribly well either. We can share in savings. The savings that we share in are different in different ways. Providers can share in the savings in some arrangements, but it's often too little, too late, and out of their control. So accountable care organizations that get paid a year later So let's say the 2014 year gets paid midway through 2015. Some of those people have already gone under, some have had to borrow, I mean, whatever. The savings come late. They're only a couple of percent, so they're not necessarily enough to motivate a lot. And then a lot of what happens to the patient is not under their direct control. So they send the patient off to get that back surgery, and they don't have any control over that. So that one works some, but not a lot. You can have investors share in savings. This is happening at an incredible rate, and people don't realize it. That those bundlers that convene everybody and make the arrangements for, say, a hip surgery bundle, so the 90 days that involve the hip surgery and the 90 days after, and if you bring it in at less than the expected cost, you get half of the savings from Medicare. Most of that money is going to commercial shareholders. It's not even going to the providers. It's going to companies that have put this together. At the present time, there are more than $4 billion under contract to one company. That company takes 5% of all Medicare expenditures out of the system. So it's no longer being used for services. It's being used to pay shareholders. There are people who think that's a nifty idea. It's a clever little investment, but it also means that public money is being drained from the trust fund and not being used to provide services. We can have quality incentives, so you can have better payment if you bring in higher quality, but at least for people with chronic illness, the quality measures, or serious chronic illness, the quality measures tend to be very imperfect at best, and often rather dysfunctional. So yes, it's very important to manage most diabetics by the standard parameters. Get their hemoglobin A1C down, get them exercising, all that sort of thing. But there comes a point in your life where that isn't the most important goal, where you're living with the effects of a stroke, where you're 92 years old and barely able to get around, where the risks of hypoglycemia become higher than the risks of not having good diabetic control. So at some point, the quality incentives the quality metrics need to be very different, and we haven't bothered to develop those. So the quality metrics we have for serious chronic illness are almost not present. We have pressure ulcers, we have pain a little bit, we measure pain sort of. We have a little bit of measurement of advanced care planning. We have now falls with injury. That's it. That's all the ones there are 320 metrics being used by Medicare in one way or another, in one program or another. There are 12 that apply to serious chronic illness. And there are some that are actually inimical, that are harmful. My 62-year-old person with early onset dementia, who is kind of barely coping and has a family in disarray, is still going to count as a ding against me if I don't get her mammogram. Who wanted a mammogram on this person? You have the rate of mammograms among people who have known metastatic cancer is now down to about 1 in 4. 1 in 4? Why are we doing a mammogram on someone dying of lung cancer or kidney cancer? This is crazy. But because it counts in the denominator and the numerator for whether the doctor gets a quality incentive. So the quality incentives could work, but they aren't working terribly well. But Medicare and Medicaid have vowed to shift from volume-based to value-based payment. So how's that working out? So what matters to people who are living with serious illness and disability toward the end of life? You all know some people like that. Your parents, your grandparents. Doesn't look like anybody in the room is quite there yet. But what matters? What matters to my mom now? What do you think? Comfort? I hear comfort. Yep, that counts. What else? Safety. Safety, okay. Independence, okay. Yeah, those are the kinds of things that matter. Anybody know of any measures that we actually apply to see if those things are being achieved? I would say that one of the things that matters a lot is relationships, being able to stay in touch with the world, not being isolated. Control, autonomy, finances, dignity, respect, being your own person. Familiarity, meaningfulness, the significance of your life and your presence in the world. Comfort, which someone mentioned. Confidence, so that you aren't constantly in terror, but you're sure that things will work in your favor and well. And survival matters. People are not eager to exit the world. What do we measure? So these are the kinds of things that matter once you're very old and frail. Here's what we measure in nursing homes. Skim down that list. That's what's on Nursing Home Compare. Any match with what counts? Now these are important things. I'm not saying they're unimportant. I mean, you know, I don't want a pressure ulcer, and I suppose it's worth throwing around some flu vaccine. It's more important to vaccinate the staff and all the regular visitors, but you know, okay, it's harmless, we should do that. But look at the rest of these things. You know, I mean, some of them are really rare, but even so, we aren't measuring any of the things that we counted as being important, except maybe a little bit gets to comfort. Then in home care, we measure some additional things. We measure many of the same things we did in nursing homes. Skim down this list. Think my mom's going to improve? Think that you ought to measure her home care in terms of whether she improves her mobility or just doesn't get a lot worse a lot faster? We don't measure that. We measure whether you improve. It's America. You're supposed to improve. You're supposed to keep getting better, right? Well, you know, there comes a point where that's not really likely. But this is what we actually measure. So what's missing? Most of what matters most. And we don't focus on the things that matter most to this population. We don't customize to patient and family priorities. You know, my mom's going to be in a different position than your mom or your grandma. They're going to have different histories, they're going to have different resources, they're going to have different aspirations and fears. I've had patients who wanted desperately to do anything they could to advantage their disabled 55-year-old son who, you know, they didn't want to use up their money, they didn't want to lose the house, they didn't want, you know, I've had people who didn't want to lose the business, didn't want to lose the farm, had people who just were scared of pain. I've had people who wanted to be sure that they were going to die out of doors so their spirit could go free. I mean, people have their own unique issues as they grow very old. This is the only thing you'll remember for sure out of my lecture. I've had two elderly gentlemen who confided to me that they wanted to be sure to be schnockered if they ever got to the point where they were babbling, because they did not want to call out to Maud while Mabel was at the bedside. You can think on that a minute. People have their personal priorities, and we have to be in a position to accommodate them. But do we measure? Do we even record people's personal priorities? Is there a slot in your record to put people's goals, what they're afraid of, what they most aspire to? No. Most of your records don't even have a slot to put down the family caregiver, the name and phone number. You know, I mean, the degree to which we ignore what matters most is just amazing. How about meaningfulness? The person who wants to stay allegiant to their religion, the person who wants to get in touch with a long-lost family member, the person who wants to finish the great American novel or watch a flower bloom, whatever it is that's meaningful to them. Comfort except for serious pain. We are more and more attentive to serious pain, but beyond that, the person who's suffering with muscle aches, the person who's suffering with arthritis, the person who has vision problems and needs some special glasses, the person who has hearing problems, we don't pay attention to those, we don't measure anything. Independence and control, we don't measure that. Finances, lots and lots of people as they're living with serious illness desperately do not want to become bankrupt. They may only have a tiny amount of money, but they want to hang on to it. They might want it to be a legacy for the grandchild. They might just want to still have control over some piece of their life. To go on to Medicaid means having no more than $30 or $40 at your disposal each month. So you can't hardly buy a gift for the granddaughter. You know, it's just a tiny amount of control you have. And the other thing we're missing is any kind of a public health perspective. So even if we could tell whether your grandma did okay, we don't know whether all the grandmas in Savannah do okay or not, because we don't bother to aggregate at a community level. You can't tell whether you're doing better or worse than you were doing a couple years ago. You can't tell whether you're doing better or worse than Atlanta, because we don't measure that way. We can tell you whether this nursing home has a high rate of pressure ulcers without lots of adjustment on it and, you know, accommodation to how sick the patients were. We can tell you a little bit about how good this home care agency is, maybe even about how good this doctor is, But we can't tell you whether you're going to do better or worse growing old in Savannah than you would have 5 years ago, because we simply do not have a public health perspective on this part of life. So why is that? That's because it's new. It's because we haven't thought about this part of life. It's because we think that if we all exercise and eat our yogurt and do our yoga, we will all somehow have a wonderful period right through to the end of life, and then somehow just evaporate. I mean, we don't really deal with what that downward slope is going to be like. It's time we start dealing with it. The average duration of self-care disability, ADL disability, the inability to take care of your own body on a daily basis, is now longer than 2 years. The average is longer than 2 years. For people who have a period of self-care disability, the average is much longer, because it's about half of us who have a substantial period of self-care disability. Women are much longer than men. We have more arthritis and less heart attacks, so we get to live longer with our self-care disability. We also have this clever arrangement in which women on the whole tend to marry men somewhat older than themselves, and men tend to die somewhat younger than women. So women end up with 7 years on average of living alone. Men on average have no years of living alone. They have a built-in caregiver on the whole, whereas women do not have a built-in caregiver, and therefore have to rely on someone else, either someone else in the family or a paid caregiver. So nursing homes are all stocked with old women. Now comes the thorough scrambler, MACRA. Anybody here heard of MACRA? How many people have heard of MACRA? Like 10 people in the room? This is what's going to thoroughly scramble physician and physician-like payment. Anybody Medicare pays directly in Part B. So social workers, physicians, nurse practitioners, dietitians who work on diabetes. So MACRA is the substitute for what was called the sustainable growth rate, which was that horrible thing that every year Congress overrode because they couldn't stand to actually cut Medicare payments by the amount they would have to cut them. So they kept kind of putting this off, and then this year they finally passed a bill that got rid of the sustainable growth rate and substituted MACRA. Well, MACRA is composed of 2 parts. One part is called MIPS, one part is called APM. I'll tell you a little bit about it. I'm not going to spend a lot of time on this, but I'm happy to talk with you in rump groups around breaks. MIPS is what you're automatically in. So all of your doctors will automatically be in MIPS. And MIPS pays the doctor what the doctor expects to be paid, times a factor that changes that by all of their payments by some increase or decrease. The score is set by quality, cost, use of information technology, and quality improvement. Sounds reasonable, right? One thing is it's a zero-sum game. So the doctors who win are balanced by the doctors who lose. So every doctor who gets a 5% gain, there's some doctor getting a 5% loss. Who will lose in MIPS? Bad doctors, presumably, people whose quality scores are horrible. But also, systematically, everybody who takes care of very sick patients. Because we have high costs, we work with people who are not in IT systems. They're in nursing homes, home care, and at home, where IT systems are poor. And the quality measures, as I've just shown you, are all bad. They're all not appropriate for this group of people. So get measured by sending people off for mammograms and a population of people who shouldn't have them, you're going to score badly if you do the right thing. So the patients, the doctors and nurse practitioners and physician assistants and dietitians and anybody else being paid under Part B are going to lose under MIPS. Now, everybody's scared of losing under MIPS. The average will keep going up, presumably. So even if today you get a 2% increase, in 3 or 4 years you might be doing exactly the same thing, you might now be getting a 2 or 3% decrease. So everybody's scared of MIPS. So what's the alternative? Alternative payment models. So everybody wants out of MIPS. They want alternative payment models, which gives you a 5% bonus on your Medicare billing. Sounds terrific, right? What's an alternative payment model? Some patient-centered medical homes will count. CMS has not been clear about exactly what will be required, but they are making noises that you have to be taking downside risk. Taking downside risk in a single doctor's office or a small group of 4 or 5 docs and 2 or 3 NPs, that's going to be really scary. You take one patient who has a calamitous course and suddenly you're on the wrong side. So how to do patient-centered medical homes is still up in the air. Some ACOs, accountable care organizations, will count. Probably only those that take what is called downside risk. That means they're at risk of having to pay back money, not just getting paid money. Now the ACOs are saying, but wait a minute, it's costing us a couple $1 million just to operate an ACO every year. Why isn't that the downside risk? And thus far CMS is saying, no, we won't count that. That's just your cost of doing business. So we'll see. Some bundles might count. What else will count? Who knows? This goes into effect next year, and the regulations are due to come out in November. So everybody's scrambling to try to build an an alternative payment model. But exactly what will count as an alternative payment model, who knows? You get the 5% bonus to have 25% of your patients in an alternative payment model in 2 years, and then the threshold goes up. So within 5 years, you have to have 75% of your patients in an alternative payment model in order to keep getting the bonus. So CMS is driving hard to get all patients into an alternative payment model. They're trying to make MIPS very unappealing, trying to make alternative payment models pretty rigid, and the way that all doctors will get paid. All doctors and anybody else who gets paid in Part B. So that's the big scrambler coming at us, and what's really surprising is that almost none of us know it. So professional organizations like cardiology organizations are all over this. Public, no idea. Most doctors, no idea. Most nurses, no idea. But this is going to be a major change. So what counts as value-based purchasing and what counts as an alternative payment model is going to be terribly important. And the question is, does it matter? Yeah, it matters a lot. We are going to, if we don't do anything, if we just allow this to drift, we are going to drive out of practice almost everybody who takes care of poor, very sick patients. So something has to be done to rescue that kind of patients. So here's my winning strategy. Build a high reliability model, estimate new expenditures, avoided expenditures, and net savings, find a way to make it sustainable, align the incentives, including pride in work and pride by the community, making people no longer fearful of their care system. And for frail elderly people specifically, integrate long-term services and supportive services. It is not a good idea to have excellent medical care and no food. It is not a good idea to have excellent medical care and no housing. It is not a good idea to have people isolated and scared. Remember that list you helped me put together of what matters to people? What matters to people is much more than just whether their hemoglobin A1C is under control. So let's put together care systems that attend to long-term care. I think we have to work within the available funds. The number of people coming at us who will be old and frail together is enormous. All those kids that we were so proud of marching off to school in 1950s, they're all going to be 80 in the 2030s. So we are going to double the number of frail elderly people between 2000 and now, double it again between now and 2050. So we will suddenly become a nation full of elderly people. We will have many more elderly people than children. And we need to be aware of the funding available. We have to, I think, take responsibility for a geographic community, and I'll come back to that a bit. But people become much more tied to their community as they get very old and frail. They can't just up and move to another place. They can't go to another city for a second opinion on spoon feeding. Spoon feeding's got to come to them 3 or 4 times a day. It's got to happen where they live over and over again in a reliable way. Your circle of how far out you can reach becomes smaller and smaller as you get very old. You can no longer drive, might not be able to take the bus. It's very hard to get around. And so I think the community becomes more and more important. And we need to learn a lot because we haven't had this challenge until now. So we need to not assume we know the answers, but to really build learning organizations. So here's what we've come to. These are the 6 key pieces, and they have to all come together. So the 6 key pieces are frail elders, that piece of life, in a geographic community. Have to start seeing frail elders as a different population, just like you see a pregnant woman as a different population than the ordinary run-of-the-mill patient coming to a doctor. Pregnant women are sent to obstetricians. I think frail elderly people need to be sent to a very customized care system that includes long-term care. We need to notice that this part of life is different, has different priorities, needs different services. We need person-driven care plans, need to actually reflect those priorities people have. Need medical care that's really appropriate for this population, really working on maintaining function, working on keeping people at home, being willing to mobilize services to the home, recognizing that death is in store and all the decisions are being made in the context of a limited lifespan. We need the health, social and supportive services to be present as full equals, not as beggars that are taking the crumbs from the table. I was just in Detroit earlier this week. In Detroit, the wait list for Meals on Wheels is 1 year long. People wait 1 year to get food. If we waited 1 year for mitral valve surgery, all the surgeons would be up in arms. I have yet to see any professional group have on their policy agenda that every person in the US should be able to get food. This is outrageous, and yet, where's the outrage? Where are people who are upset? Then I think we need a community board that sets the priorities for each community, because communities have different strengths, different possibilities, different things to work with. And then how could you fund this? Well, for the next decade in most parts of the country, you could fund it on the waste in medical care. You could fund it on having my mother get the home care and not all that other stuff. You could fund it on having that happen over and over and over again and harvesting the waste in medical care, investing it in the community. Not giving it to shareholders, not giving much of it to providers, instead actually working to build the community strength. Then we can really learn what a good care system looks like and how to build it. People say, well, how are you going to find the frail elders? I think it's pretty easy. I mean, find elderly people with an ADL deficit or who can't manage their own affairs and move them in unless they say no. And then take older people who are just very fragile. They're still doing okay. They're not yet really disabled, but they want a care system that works and allow them to opt in. Something like this would work in most communities. How about care planning? Well, this is, I think, the kind of thing we're looking for in care planning. It's not just advanced care planning. It's not just how do you want to die. It's how do you want to live? Who's going to take care of you? Where are you going to be? How are you going to get food in? It's the 1,000 little things that make up a thoroughly rewarding life. So you really need a plan for those services. And then even in the few places where I've found good care planning happening, it's never evaluated. I mean, I think it's kind of good, but how about going a couple months later and saying, well, how did that work out? Was that good? What did we miss? What should we have been asking about that we didn't ask about? What are we planning for that really is irrelevant? And then a really clever thing is if you had care plans for all the frail elders in Savannah, and you had them all electronically stacked up here and being able to analyze them on my computer, you would have a remarkable tool for planning for frail elders in Savannah. You would know how many people need in-home care. You'd know how many people need doctors to visit them at home. You'd know a whole lot about what the community needs. And you could see the gaps between what is available and what you need. So you could be able to see whether the care plans are being distorted because we don't have any workforce for dementia patients. And we need to train up a workforce for dementia patients. Or that we don't have any geriatric psychiatrists, and we need to recruit that. But we could start seeing what it is we need, and we could see whether we're improving over time and how we compare to other communities. So we could start thinking in terms of a public health function. These are the elements in CMS's, the Medicare program's chronic care management code as part of an optimal care plan. It's not a bad list, and this is the only one that exists thus far in federal regulation. Just another story to match with my mother's. This is an elderly gentleman in his 90s, very sick. He lived a year in New York City, bouncing from one place to another. His name is Mr. Andre. That's his daughter with him. She had to work, so she couldn't actually provide round-the-clock care. So he was living alone. He was hospitalized multiple times. He was in 3 different nursing homes. He had pressure ulcers. He had multiple errors in his medications. He finally got home with AIDS for 2 nights. And then the program that took him home said he's going to live too long and brought him back to the hospital. So the only thing that he wanted was to be at home. He said that over and over and over again. Medicare and Medicaid spent $1 million in a year on his care. And he never got home except for those 2 nights. That's the kind of distortion that we need to tackle. So we need to geriatricize medical care, make sure we have continuity, reliability, self-management, respecting family and other caregivers, starting to even document who they are, make sure they're trained, attend to the burden of medical care. We often put people through so much medical care that they can't do anything else. So they're just constantly worried about the next pill, the next test, the special diet, whatever. Moving services to the home, preventing falls. 1/10 of all falls of elderly people, or 1/10 of all hospitalizations of elderly people are from falls. We need to really work on enhancing meaningfulness, making it possible for people to live full and thriving lives. And then I think we have to really work on what we understand about dementia. Dementia is, I think, very perplexing to the American psyche. What counts as good care is not at all clear. Those are the kinds of things that go into geriatricizing medical care. Let me tell you a little bit about healthcare spending. These are various developed countries across the bottom, and this is how much they spend per capita. And you're probably used to seeing this kind of a graph that, we spend a whole lot more than most other countries spend. The Swiss, the 81% is the average of the other 10 countries. So the Swiss are the highest. But look at what we get. We get bad life expectancy, we get bad infant mortality, we get bad survival spans. So you want your money back? This is mostly public money. I mean, it might be through insurance programs, but it's, in that sense, shared funds. Look what happens when we look at that kind of a graph and add social services spending. So this is the spending on housing, food, supportive services. Turns out we're just kind of in the middle of the pack. But look at the ratio. That's the ratio across all those different countries. So the US ratio is 75%, or we spend 75% of what we spend on medical care on social services. So we spend less on social services than we do on medical care. The average of other developed countries is almost double spending on social services compared to medical care. So the amount they spend on medical care is almost doubled by the amount they spend on social services. That's why Detroit has a 1-year wait for Meals on Wheels. That's why people are homeless in this country. That's why I can write a $100,000 drug prescription with a sweep of my pen and it actually gets delivered. But I can't get a person food. I can't get them a visitor. I can't get them a place to live, except in a nursing home. So this is a fundamental challenge to us. So we have the Older Americans Act as our federal funding for social services. The Older Americans Act was passed with Medicare and Medicaid in 1965. They were seen as a 3-legged stool, is what was talked about at the time, that you needed services for the poor, you needed services for the elderly, and then you needed a way to provide social services and supportive services. So this is the number of people since 2004 to 2020, goes up by 54%. That's the amount we're spending on Medicare, going up by 186%. Anyone have a guess of how much we're spending on the Older Americans Act? There you go. And where's the outrage? Why are we not upset that we aren't feeding people? We have our social services organized over here. We have our medical services over there, and never the twain shall meet, except, of course, at every patient. But we have them in different training programs. We have them in different funding lines. We have them even in different committees in Congress. And unlike every other country, we have no spot at which they come together. We have no integrator that's seeing the balance of needs. So we end up with inappropriate, unreliable, unmanaged, wasteful care and huge gaps. Could we do something on a population basis that would illuminate what we're up to? This is Sweden. This is Jönköping, Sweden. The little blue, light blue area up there at the top is a lake. So this is one of their finger lakes. 3 counties, that number of municipalities. This is the public dashboard for elder care in this area. It is online. You can look at it at any time. It has line graphs and bar graphs showing the progress in each municipality for 20 different measures of elder care. How many people have pressure ulcers? How many are taking psychotropics? How many people have a care plan? How many people have 90% of their care plan implemented? It's a remarkable little thing. What happens when you put that online? County councils start taking it up. Municipal, city councils start taking it up. They start saying, why are we still twice as high as this other place? Why are we using twice as many psychotropics or have twice as many pressure ulcers? What are we doing about that? Becomes something in the newspaper, becomes something we talk about, becomes something you can grasp. We don't have anything like that, but we could. This is not out of reach. We just haven't bothered to think about it. How could you develop local management? There are lots of ways. Different communities have different strengths. Already 3 entities have to do a chronic illness mapping for your community. The Public Health Office, the Area Agency on Aging, and any nonprofit hospital. In a very few areas in the country, they're actually merging their resources and doing it together. What a clever idea. Then instead of a whitewash that basically says nothing because they only put $10,000 into it, you actually get a serious review of how the community is doing. There are a number of ways you could build a community entity that would monitor and manage the care system, but you still are going to need some money. So you're going to need some new spending. Where will it come from? I think it right now can come from the waste in medical care. Anywhere in the country, it can come from the waste in medical care. So we took 4 communities. We estimated the proportion of their population that was frail. We worked with local providers to estimate, we used the actual per patient per month total costs, except for unpaid caregiving. So we pulled Medicare to Medicare funding. And then we estimated how much you could reduce that funding with good care. Nothing that's rationing care, nothing that's denying people the services they most want and need, but instead just getting rid of those stupid extra x-rays my mother got. So getting realistic goals. So then we assumed that it would take 2 years to get to full impact. We adjusted for deaths and transfers in and out. We adjusted for inflation. And here's roughly what we ended up with. So that on inpatient hospital, you reduce it by 25%, but you increase outpatient services, you increase primary care, you reduce the use of skilled nursing facilities, and you reduce long-term care. There are a bunch of others, but you get the basic idea. We did this with 4 communities around the country, and look at how much you save. This is the per person per month savings in 4 different places. Akron, Ohio, a Rust Belt city. Milwaukee is not the Milwaukee you think of. It's a suburb of Portland, Oregon, one of the skinniest healthcare systems in the country. Queens is a chunk of New York City, and Williamsburg is a rural area in Virginia. In every one of them, you would have substantial savings within 3 years. You would in fact have a positive return on investment within 2 years. So you would have enough money to begin to address those social service needs really pretty promptly. So 15,000 frail elders as the steady caseload. We made conservative estimates of how much you could save. We worked with people in the communities as to how they thought they could enroll people and what they thought they could do in what kind of time frame. Within 3 years, you'd have a return on investment of $22 million spread across 4 communities. That's beginning to make sure everybody has food. And then notice in year 3, which is when you finally get full effect, you would have on the order of $20 million per year saved out of the medical care system. That's enough to develop those dashboards from Sweden and make sure people have housing and food. So what to aim for is a fully integrated system with monitoring and management, honest care plans that people are being told what they really face, are being helped to make the best possible arrangements. Have the client-family perspective really guide the care plans, not the doctor's perspective. Have an adequate supply of the critically important supportive services, so you aren't having to put someone in a nursing home because you can't get the Meals on Wheels. You have to have medical services routinely attentive to keeping the person as functional, comfortable, and living as meaningful a life as possible. And then it has to be sustainable for the family and the community and for the country. Now, would this be an APM? Is it value-based? I think so, but it's not at all clear what CMS will end up wanting. What could you do about this? We need to make this a public issue. We need people to be knowledgeable and speaking out. When Representative Carter comes through next time, you need to nail him and get him on board with this. We need to encourage allowing innovation, not keep everything so rigid. Let's figure out how to make big changes in how we take care of frail elders. We need population-based metrics, not just is this patient doing okay or is this nursing home, but how is Savannah doing? How's Atlanta doing? We need to be able to, in addition to knowing how individual providers are doing, we need to know how the population is doing, because people move around. We need appropriate measures of quality, measuring some of those things you brought up right at the beginning. Are people meaningfully engaged in their community? Are they comfortable? Are they confident? The things that matter to people. Are you slowing down the rate of spend down? Are you having fewer people having to become bankrupt in order to get medical care? We are running something called the Party Platform Project. This is entirely volunteer. We have done the research to figure out which states have party platforms, and we're encouraging volunteers to help us get caregiver issues on the party platforms in both parties in as many states as possible. Last time around, just 4 years ago, there was one state, one party that said anything about elder care other than preserve Medicare, preserve Social Security. And that was Hawaii Democrats, who said that family caregivers needed a fair shake, needed support. That could be in both parties' platforms and thereby make it up to the national platform, get thousands of politicians willing to talk about this issue. Once Sarah Palin talked about death panels, nobody will talk about frail elders or death anymore for a decade. It's time to undo that. So we need to have people sign up. There's the opportunities in Georgia. I can tell you more about them. But if you're from other states, just go to the website, find out what's needed in your state. If there's no party platforms in your state, and that's true of about 10 states, just find a friend in a state nearby. If we could get, and it usually takes only about 5 phone calls. You call one person, they say, well, the right person is that person. Send them an email, send them text that you can pull straight from the website. We already have 8 states in which this is moving forward. Talk with every political leader and wannabe about these issues. Get them having to answer. How could we have had this many CNN debates, town halls, all that stuff with the presidential candidates, and not a single question has yet been asked about how we're going to take care of an aging society? Now Hillary has a caregiver platform and a dementia platform. No one else has anything, except of course Bernie says we want Medicare for all. I mean, I admire Bernie, but I actually don't want Medicare for Medicare patients. I want something better than Medicare for Medicare patients. Medicare's fine for the rest of us, but frail old people need something better than Medicare. So, what is it we need to do? We need to stop being so daggone polite. We need to raise our voices. We need to show up. We need to yell. We need to talk to people. We need to push the newspapers to carry these stories. We need to teach people how to complain effectively. We are so good at papering over the problems. We say to a patient or family, well, that didn't really go quite right, but let's see what we can do to get it to come out right. And we don't say, incidentally, at the end of all this, remember to write a letter to the CEO about how mad you are today. You know, we'll make this come out okay for your family member, but don't forget to raise your voice, because that's what changes things. That's what changes things. And we need advocacy. We need to have 2% of everybody in the room, 2% of your energy going to changing the system. The one thing you know, absolutely, you know it in your soul and you know it today, is that you do not want to grow old and frail in the care system we have now. That makes all of us advocates. It's the minority group to which we all aspire. We all want to grow old. And we want to have decent care system available when we get there. So, you know, speak up. Again, the Medicaring model is, I think, the only one on the table in policy at the present time that actually has a sustainable plan, would build the care system of the future. It does need to be matched with an eventual way to save more money toward long-term care needs. There's some policy coming on the table in Washington now to maybe address that again. That could all come together in the 2030s and we could live comfortably into the future. Because if we don't, then what we will do is to learn to abandon people. How many stories have you seen about the wait lists for Meals on Wheels? How many stories have you seen about people who are locked in a basement because they're demented and their family has no other alternatives? Not very many, and there are a lot of such people. So we need to really speak up, build the care system of the future. We can have what we want and need when we are old and frail, but only if we speak up now. Because if we wait till 2030, we will be so overwhelmed with the numbers, we will all learn to turn our backs. We will learn to allow people to choose to be dead rather than to live out the end of life. And that's not the future we want. So join with me, join in the party platform project at least, speak up to your representatives, get knowledgeable about MACRA, and try to build that care system of the future. The future is going to be in chronic illness. We can now treat acute illness so quickly. You know, when I was in training, we had people 2 or 3 weeks in the hospital with ulcer disease. We now give them an antibiotic and they're never even in the hospital. But my elderly patients, they are really, really sick. Lots of disabled people are really, really sick. And we haven't rebuilt the care system around that. We built the care system around 50-year-old men in suits who are scared of heart attacks. We did not build it around 88-year-old ladies in second floor walk-ups scared of not getting food. We need to rebuild the care system around the population we're serving, and we will be that population. So join in.